Today we have come together to discuss on a very common and very useful topic for everyone on daily practice, which is diabetes and related kidney disorders. Diabetes is a big issue in across the globe, and India, especially India, is becoming a hub for the same. And every physician is seeing diabetes patients, and kidney disease associated with diabetes are one of the most common reasons why people end up in chronic kidney disease, dialysis, or need for renal replacement therapy like transplant. So today's topic is on diabetic and kidney disease. So I will take on diabetes and kidney disease as separate topics, and then I will tell you the link to join. So the first topic is diabetes. Now diabetes could be multiple types, type 1, type 2, but type 2 being the most common, and we see as an adult physician, we see type 2 very commonly. So I'll talk about type 2. So in type 2, there are two big issues. One is the insulin resistance that we see. Second is the decreased insulin to the demand of the body. So we have to act on both sides. Now, people who get insulin resistance, most of the common reasons are the obesity, the sedentary lifestyle, and so on. And the other is the decreased amount of insulin that is needed to counter the sugar in the blood. So the first thing is to decrease the insulin resistance. There are many ways of decreasing insulin resistance, out of which one is exercise. The exercise causes the muscles to start consuming glucose in a very easy way to explain the same. And the other is to lose weight. When you do exercise, you will start losing weight. So when you lose weight, your muscles and other areas where the GLUT receptors are available, you have to decrease your sugar. So insulin receptors become sensitive to the same, and insulin decreases. The sugar decreases in the blood, and that is how you improve your glucose insulin resistance. There are pharmaceutical ways of decreasing insulin resistance by usage of commonly used drugs like metformin and glitazones. So these are the two class of drugs which help in the same. Second is the increase the dose of insulin, in which the common ways are using oral pills and by giving insulin. In kidney disease patients, there are limited oral drugs that we can use. So a patient should not be very hesitant in starting insulin to control diabetes. So insulin almost comes out of no harm except the prick that the patient has to take. So the sensitivity to the patient's, sensitivity to the physician itself should be, the threshold has to be very low to start insulin in kidney disease patients to get adequate sugar control in the form of 3-month average called HbA1c. Now let's talk about chronic kidney disease. Now chronic kidney disease is something structural and functional problem in the kidney which lasts around more than 3 months. So any problem that you have related to diabetes, related to blood pressure, related to kidney cyst, or related to any other problems in the kidney which are lasting and destroying your kidneys over time and have lasted more than 3 months and not improving, will fall under the category of chronic kidney disease. Now one aspect which every patient should know, that chronic kidney disease is a self-swelling building. Now the moment your GFR is less than 90, the other nephrons, the one kidney has almost around 1 billion nephrons. So the moment your few nephrons are not working, your kidney partially is not working, the pressure of that kidney working comes on the remaining filtering units, and they have to overwork. And over time, because of this particular phenomena, your kidneys, the other filter starts to deteriorate, and your kidneys deteriorate on itself, even without any further injury. So chronic kidney disease is a progressive disease, and it is a very difficult thing to manage in current scenario. But fortunately, we have more drugs coming in which are helping us to decrease the pressure on the remaining filters. The few of the drugs that we commonly use are a class of ACE and ARBs, in which the commonly used drugs are like telmisartan, olmesartan, and other losartan that we commonly use. The second class of drugs which have come recently into clinical practice is SGLT2 inhibitors. They also help us in decreasing the pressure on the remaining filtering units. And one drug recently about to be launched in India is a drug which is a newer form of an old drug, spironolactone. The recent drug is called Finrenone, and it will be launched soon. And these three drugs combined have their own pitfalls, but these are the three weapons in your armamentarium to decrease the pressure on the remaining filtering units, to slow down the progression of your kidney disease. Now, once you have diabetes and you are having kidney problems, you should be able to classify whether the problem in the kidney that you are facing is directly related to the diabetes, or it could be some other reasons as well. In a patient who has diabetes and who has kidney problems, don't jump to a direct conclusion that diabetes has caused this kidney problem. You should, try to classify the kidney problem into various aspects. Now, a diabetic patient who is having kidney problems secondary to diabetes usually presents, as a diabetes of 15-20 years and a blood pressure of around 10 to 12 years, and then you see proteinuria coming in, which is progressively rising. But this is a classic prototype. There are non-proteinuric diabetics as well. So you have to keep your eyes and ears open, see your reports properly, and don't be in a hurry to classify this patient as diabetic-related kidney disorders. Because frankly speaking, diabetic-related kidney disorders, we don't have a short way of returning to normal kidney function. On the contrary, if you can find a different reason for your kidneys to stop functioning, or the protein that is coming out a different reason. One of the common reasons would be membranous nephropathy that is associated with diabetes. So if you are able to find that out, it will be a real boon to the patient's health, that there is another form of injury that is happening to the kidney which might be totally reversible, unlike kidney diseases. So if you see protein coming out of your kidneys and you have diabetes, you have to do two things. One is to quantify that amount of protein. What is the 24-hour urine protein that comes out? Second is you have to show an eye specialist and see whether your retina is getting affected with the same or not. There are many other ways, but these are the two thumb rules that you should see. You should quantify the amount of protein and see whether your eyes are getting damaged by diabetes also or not. If your eyes are getting damaged and if your proteinuria, your kidney sizes are normal, most of the time it will come out to be diabetic kidney disease. Your kidney disease are secondary to diabetes. But many a times your eyes are normal, the other organs are normal, only kidneys are throwing out protein. Diabetes is only for a short duration, so it might not be related to diabetes. So at that point of time, you have to see the creatinine, you have to see the GFR of the patient, and many a times you need a biopsy also to find out the exact cause. And the threshold to biopsy should be low in these patients in which the typical presentation of diabetes has not come. As a clinical nephrologist, I can tell you, if you see 100 patients and you try to jot down whether how many of them are non-diabetic kidney diseases, you might be able to find around 25-30 of the patients who have diabetes, who have kidney problem, but the kidney problem is not secondary to diabetes. And if you are able to find those patients out in time, you will be able to revert those kidney problems and give them a disease-free period for a long duration. So it is a real help to them. Once you have diabetes-related kidney problems, you have to see how is the blood pressure of the patient. Now, a patient who has diabetes, who has kidney problem, also might be having blood pressure. Now, blood pressure has to be controlled in a very stringent manner. If you don't control blood pressure, even if you are taking all the medicines for your kidneys and diabetes, your sugars are coming normal, but your blood pressures are not in control, your kidneys will keep on worsening. So once you have diabetes, kidney problem, blood pressure, these three becomes a triangle. You have to control the sugars, you have to control the blood pressure, you have to control the kidney disease. You have to see that you don't take any nephrotoxic agents. The commonly used nephrotoxic agents in routine practice by many patients are the painkillers. Most of these patients could be, are there in 50s, 60s. Many of them could be females suffering from osteoporosis or some chronic injury, and they might be popping pills for pain, and those could be NSAIDs, can be very harmful to the kidneys. And many times when you have kidney problems, it becomes like in commonly language a लाइलाज बीमारी हो जाती है. So they always tend to fall into non-allopathic practices and local practitioners which might not be very scientific to start with, and those drugs can be harmful. They can have heavy metals in them. They might be giving you steroids for all you know. So it is better to be in touch with a registered medical practitioner and treat your kidney problems the way the general medical guidelines are. So once you have these kidney problems, you have to see your blood pressure, you have to control your blood pressure, you have to see your diabetes, you have to control your sugars. Now once you are done with these two, you have to come back to the kidney, the third aspect of your triangle. Now once you come to kidneys, there are many aspects you can control your kidney disease problems. First and foremost is the lifestyle related problems. The first thing that you should do is to see whether how good or bad is your BMI, and you should control your weight. Try to get your BMIs into a range of between 20 to 23 to be best, and at least between 18 to 25. Both sides are problem. If you're above 25 is a problem. You're below 18, you're undernourished, and that could also be contributing to your a complication called MIA, malnutrition, inflammation, atherosclerosis, which could be detrimental to your kidneys. Second thing, once we have talked about weight, you should not be obese. Second thing is about controlling blood pressure. The third thing that you see is about diet. Now in diet, we have to divide your diet into salt related issues and protein related issues. Coming to the salt related issues. Now this is a very commonly spoken about problem, and let me tell you, the amount of salt that you need to take is around 5 grams per day. Now nobody measures or weighs their salt when they are taking. So you have to take a teaspoon, you have to flatten then out, the amount of salt that is remaining in that spoon comes out to be 5 grams per day. Trust me, it is very low, and you have to be aware and cut down your salt intake. That is how you will be able to get it down to 5 grams and below. So no eating pickles, no eating salts. Don't try to put salts in your curd and other salads, so that you are able to cut down your salt intake. Now, when you have kidney disease problems, your doctors will prescribe you medications like telmisartan and olmesartan. These are very good drugs, but the only side effect they have are potassium increase. When your GFR is below, you're on these drugs, you're bound to have high potassium. And when you take salts like rock salt and Himalayan salt and other fancy salts, they have extra potassium. So the combination of a low kidney functioning and drugs like this, plus newer drugs like I told you before about Finrenone and spironolactone and your the potassium tends to rise, and this potassium rise can be very life-threatening. It can stop your heart from beating, decreases the pulse rate, and it could be life-threatening issue. So you have to take the salt in a very limited manner, and when you are on these drugs, when you are having low kidney function, you should avoid taking rock salt and Himalayan salt and any other fancy salt with a little low sodium but a considerably high potassium. The other things that you should about from salt is about the protein. Now protein, when this is a society of internet users, and everybody comes online and sees you have to decrease the restriction of protein in a kidney disease patient, but this could be a real side effect actually. Most of our Indian patients, many of them are vegetarians. Vegetarian food does not have a lot of protein, and these patients are anyways, when they become a chronic kidney disease patient, they become weak, their immunities are low, and they follow a diet called low protein, in which the protein is already very less. So they fall into a problem of malnutrition. Chronically they become very weak. They are not able to exercise. They are not able to live life up to the fullest. So I would advise protein restriction in a supervised manner is extremely necessary. Please contact your doctor to see how much protein you should take, what kind of diet you are on, and customize your diet by speaking to your physician and in consult with a dietitian. So protein restriction could be harmful. That is my take-home message. Don't blindly remove all your protein, especially if you are vegetarian. Don't try to remove all the protein from your diet. It will be more harmful than causing good to you. Once we have taken care of your salt, when we have taken care of your protein intake, the other things is the addiction. The alcohol, smoking and other things goes without saying that you have to stop them. These are extremely harmful to your weakened kidneys. So alcohol, tobacco chewing, smoking, all have to go out. Once you are done with your salt, exercise and lifestyle issues, you have to focus on exercise. Now 5 days a week, at least moderate exercise of 45 minutes to 30 to 45 minutes are recommended, and this much you should be able to do. If you are not doing this, gradually try to increase your from a 2-day schedule in a week to a 3-day schedule, and gradually increase up to 5 days minimum. You can do it 7 days, nothing like it, but at least 5 days, 45 minutes of moderate exercise. So this is extremely important. So once you're done with lifestyle issues, when you're done with your diet issues, you have to come to pharmaceutical help that we can give you to prevent your kidney problems. The first thing and foremost is we should be able to give you the drugs which I previously mentioned are the ACE and ARBs. These are the drugs which are time tested for decades, and they have the tendency to reduce your fall in GFR, but they come up with a side effect of increasing potassium that I have already alluded to. But they also come up with a point when you have sick day. So if you are on ACE and ARBs, you should follow a sick day rule. If you are on SGLT2 inhibitors, which are also newer drugs to reduce your fall in GFR, both of these drugs have to follow a sick day rule. Now, what is a sick day rule? So if you are not able to take your diet properly, if you are having vomiting, if you are feeling sick, if you are having loose motions, and you're in a place where your fluid intake is very less, these are the indications where you should stop the drugs for that duration. So if you are having loose motions, stop these drugs for a day or 2 or 3 days when if your loose motions are getting till the time they are getting better. If you are having vomiting, fever, your oral intake is less, stop these drugs for 4 or 5 days. Contact your doctor for a sick day rule protocol. They will give you that, and you should be in touch. So this becomes very important. So once you are on SGLT2 inhibitors, once you are on ACE and ARBs, and you are faring fine, over time your kidneys that will work for a longer duration at a reasonable amount of GFR. So we have covered a lot of topics. I hope you are able to cope up with the speed that I am in. So diabetes has 3 legs. One, you have to see the diabetes is in control. Second, you have to see the blood pressure is in control. Third, you have to see the CKD management. In the CKD management, there is diet, there is exercise, there is stopping of addictions if you have, following the absolute protocol for slowing growing chronic kidney disease. Now, a few small mention about a few drugs which are still not beyond doubt that they are helpful. They are still debatable. Are the class of keto analogs or are the class of probiotics and others? These are medicines which have a little bit of 19-20 19-20 का फर्क वाली दवाएं हैं और बहुत costly हैं. So in a clinical practice, when we see, these are the drugs only to be used in a limited setting when you are able to counsel the patient that all the other measures are already taken. And these are the drugs to be used at the end. And if the finances are allowing these patients, then only. Otherwise, these drugs are not very, very helpful, and they will increase the pill burden plus the financial cost burden on the patient. So it is better to avoid these drugs if at all. Once you are kidney disease patients and diabetes, you have to see the other parameters as well. You have to see your bicarbonate levels, you have to see your vitamin D levels, you have to be on some calcium pills, because the chronic kidney disease patients always have acid environment in their blood, and their bones become weak, their muscles become weak, they become sarcopenic over time. So you have to counter that bicarbonate, you have to counter that calcium, see whether you are eating any active vitamin D or not, and in newer formulations to keep your bone health in place has come. So meet your doctor, see your calcium phosphorus levels and other CKD parameters, your intact PTH levels, parathyroid hormone levels. All of these investigations are available in go-to labs, and you should do them after consulting your physician. And once we have done these investigations, you should try to correct the biochemistry of these parameters. Most commonly, when we see these diabetic patients who have kidney disease, they are anemic. Now, anemia is a big problem. They get fatigued out, they don't feel like eating, they are irritable, and they are not able to do their routine activities. So you have to see, you have to classify the anemia into frank anemia and iron deficiency. So you could not be anemic. Your hemoglobin might be 11 or 12, but you could be iron deficient still. So you do your hemoglobin levels, but at the same time try and do your iron levels as well. And if you're iron deficient, even though your hemoglobin is normal, try to improve your diet, try to take an oral pill if you're able to tolerate it, or maybe injectable drugs which are there can help you replenish your iron stores. Once your iron stores are replenished, your hemoglobin is working or not. And if your hemoglobin is still low, even after replenishing iron stores and vitamin B12 stores, you have to start something called erythropoietin or newer class of drugs that have come, HIF-PHI inhibitors, like roxadustat and the other which are coming already are in the pipeline. You can use these drugs to boost up your hemoglobin. So your hemoglobin level should remain above 10 or 11 if possible, and your blood pressure should be in control. Your other biochemistry related to your CKD and mineral bone disease should be in control. And if you are able to do all this, your chronic kidney disease progression will be very, very slow, and you'll be able to live a healthy life. I think I'll stop here, and I'll be open to any questions. My contact details are in the chat box. Feel free to mail or give me a call. Thank you.